Hello and welcome everyone. Today we'll be discussing an important topic, that is how do we escalate a vasopressor in patients who are getting admitted with septic shock. So first a case, a 65-year-old woman with AF presented with fever, dysuria, hypotension. The BP was 75 upon 40 millimeters mercury with a MAP of 52 and mild hypoxia, oxygen saturation of around 92%. She was diagnosed with community-acquired urosepsis and received Ringer's lactate and antibiotics, a very common scenario in most of the hospitals. Despite initial treatment, she remained hypotensive. The BP was 82 upon 45 with a MAP of 57 and serum lactate was elevated at 2.5. Echo showed mild reduced biventricular function and grade 1 diastolic dysfunction. Norepinephrine was initiated via peripheral IV after confirming its alignment with her goals, and she was transferred to the ICU. So the question is, what is my first choice of vasopressor? And if it is noradrenaline, why it is? Noradrenaline is generally recommended as the first line of vasopressor in septic shock based on its efficacy and also its safety profile. Exceptions are alternatives like vasopressin or phenylephrine may be considered in patients with AF or poor cardiac reserve due to the risk of rapid ventricular response. The supporting evidence, while norepinephrine is preferred over dopamine due to the low arrhythmia risk in the SOAP2 trial, there is no significant such difference in terms of mortality for either of the vasopressors except dopamine. So it's not that you can't use the other drugs, but then considering its wide usage and its safety, it can be considered as a safe choice. MAP target. So what we target is a MAP which is of around 60 to 65 and typically target to keep a cerebral autoregulation failure from occurring, which is below 60. And higher MAP targets may increase the risk of supraventricular tachycardia and mortality, especially in older patients. Now, should we administer vasopressors to peripheral IV route? Now, low dose epinephrine, that is less than 15 milligram per minute, can be safely administered via peripheral IV for short term, that is less than 72 hours. Transition to CVC if higher dosage is required, you need more vasopressors, or you think that there is going to be a more prolonged use of noradrenaline or vasopressor beyond 72 hours. Then it is better to transition into a central venous catheter. Regarding the safety, peripheral administration has a less than 5% risk of extravasation with no significant reports of tissue necrosis or limb ischemia in recent studies. But the basic idea is you can start and you should start early, but it is always better if you choose a vein using your ultrasound which is large enough and not a very small vein. So then your chances of complications become very less and it can be safely used for 72 hours without any issue. Now, when to consider a second vasopressor? A second vasopressor is generally considered when norepinephrine dose approaches zero point 0.3 mics per kg per minute. The perfusion, and if my perfusion goals are not met despite giving this vasopressor. The decision to add a second vasopressor versus increasing the current vasopressor dose involves weighing the benefits and the risks, that is, the drug that you're adding and the drug that you're giving, whether my risk benefit is fitting or not. Current guidelines weekly recommend adding vasopressin when noradrenaline dose approaches 0.25 to zero point 0.5 mics per kg per minute due to catecholamine sparing effects and potential reduction in the incidence of AF. Evidence and practical considerations. Vasopressin is usually considered as the second vasopressor. Meta-analysis suggests that adding vasopressin may reduce the incidence of AF but has inconsistent effects on mortality or renal replacement therapy. Now, timing of addition, again, the evidence is not very much. Early addition is advised for rapidly increasing norepinephrine. The VAST found lower mortality when vasopressin was added early in patients on low dose norepinephrine. Again, the definitions are vague. Early doesn't mean much. We have ultimately looking at the dose of NORAD. So more or less you can start it at around zero point 0.2 to zero point 0.3 microgram per kg per minute of noradrenaline. Escalation strategy: in rapidly decompensating patient, vasopressor escalation should not be delayed while awaiting a second vasopressor. So don't just wait if the patient is crashing that I will add a second vasopressor and see. Escalate the current vasopressor and then add the second vasopressor, and gradually if required we can reduce the first vasopressor. Now, which vasopressors to choose? Again, vasopressin, the first choice, preferred because of its ability to reduce dialysis and arrhythmia, making it the most studied and recommended secondary agent. But then we must understand it is actually the most studied one, so we don't know for sure whether we can't add others. Adrenaline is a close competitor. It can be considered, but if arrhythmia risk is less, you can consider using it. If impaired cardiac output contributes to the shock, then you can also think of using it. However, as I have already said, the evidence of using adrenaline is limited because most of the studies are focusing on vasopressin because it is a totally different receptor on which it acts. So they want to reduce the catecholamine usage. Now, angiotensin 2 not routinely used due to the cost, limited evidence, but the limited trials have shown that it can expedite MAP achievement. Next is steroids. Adding steroids to the vasopressor, often with the second vasopressor initiation, is usually done. Hydrocortisone 50 mg IV 6 hourly plus fluorocortisone 50 mg orally daily for 7 days without tapering is used. The mechanism over here is corticosteroids may reduce vasoplasia through immunogenic effects and actions on endothelial glucocorticoid receptors, potentially acting as a vasopressor sparing agent. Strong evidence supports steroid in increasing BP and shortening shock duration. And this has been conclusively shown in most of the trials, but the mortality benefit has not been seen. Regarding the adverse effects, you may find hyperglycemia, hypernatremia, and muscle weakness. Regarding the fluorocortisone, the rationale is combining it with hydrocortisone based on the evidence from large trials which have shown mortality benefit because of it has got some additional benefits by retaining the sodium. Regarding methylene blue, it is reserved for refractory shock when you have already giving multiple vasopressors and steroids. It improves the MAP and the heart rate and likely through inhibition of nitric oxide pathways. Limited and mostly pilot studies have been done due to temporary increase in BP to allow other intervention. If you want more detailed view on methylene blue in septic shock, you can see our video which was uploaded before. Regarding vitamin C and thiamine, again they can be used as we have already used when we start our steroid and the second vasopressor. Multiple RCTs have failed to show much benefit and some have even shown harm. So it is currently not really recommended as of now. Now coming back to a case. After the initial improvement, the patient's condition worsened on day 5 with persistent hypotension despite high dose norepinephrine, that is 0.5 mics per kg per minute, and vasopressin 2.4 units per hour, and epinephrine 0.3 milligrams per kg per minute. Now, hydrocortisone and fluorocortisone were started, but patient exhibited signs of poor perfusion. So there was mottling, prolonged capillary time, elevated lactates. Diagnostic evaluation ruled out hemorrhage, abdominal compartment syndrome, pneumothorax, cardiac tamponade with unchanged echocardiographic findings. So what do we do now? So how do we diagnostically evaluate such patients? What you need to consider is persistent or worsening shock after initial resuscitation and source control should prompt evaluation for nosocomial infections, pulmonary embolism, abdominal compartment syndrome, septic cardiomyopathy, and arrhythmias. The recommended evaluations are imaging studies, repeating the cultures, and definitely putting in advanced hemodynamic monitoring. Vasopressor dose escalation. Now, how much we can escalate? There is no such fixed dose limits. We don't have any strict limits beyond which we can't go for MAP requirement based on the norepinephrine and epinephrine. Regarding vasopressin, it is usually not titrated above 2.4 units per hour due to the concerns of cardiac output and perfusion at higher dosages. Coming to survival, studies show variable survival rates 10 to 54% in patients requiring high dose vasopressor. Here the high dose means more than 1 milligram per kg per minute norepinephrine equivalent. Regarding central arterial catheters, central arterial catheters, that is femoral or axillary, are often placed if the patient is having this refractory or septic shock. And recommendation is the campaign favors invasive arterial pressure monitoring, though they do not specify central or peripheral, though we would recommend central pressure to be of more benefit when the shock is this refractory. Management of acidosis is very important. Always correct the acidosis. Soda bicarb is administered to correct the acidemia, targeting a pH of more than 7.3. And this is based on the evidence, that is the BICAR ICU trial, which showed lower mortality and more vasopressor free days in patients of AKI who received soda bicarb infusion. So you can consider continuous renal replacement therapy also if you want to correct for the acidosis, if it is not controlled by bicarb. Regarding weaning of the vasopressor, the weaning strategy is discontinue the norepinephrine first, then follow it up with vasopressin. Studies suggest that stopping vasopressin first can lead to increased hypotension. Persistent vasoplagia and weaning challenges. For patients with persistent mild vasoplagia but clinical improvement, the MAP target can be reduced to facilitate vasopressor weaning. Adjusting or discontinuing the sedatives also helps. Additional diagnostic can be done to rule out ongoing issues for the vasopressor dependence, like an intra-abdominal sepsis probably. Regarding the role of midodrine, the indication is midodrine is an oral alpha-1 adrenergic agonist, which may be considered for patients who cannot be weaned off IV vasopressors despite targeting lower MAPs and minimizing sedations. The MIDAS trial showed overall no benefits in accelerating liberation from IV vasopressors, though subgroup did so benefit. Regarding the administration, it is typically prescribed 10 to 20 milligram every 8 hourly with a plan of tapering or discontinuing after 24 to 48 hours if no improvement is seen. Regarding its use post-discharge, which requires careful planning for cessation. Initial management regarding. So to summarize, in the initial management, begin with norepinephrine targeting a MAP of 60 to 65. Start with NORAD, add vasopressin and steroids. If the NORAD dose is escalating beyond 0.2 microgram per kg per minute, and if we can consider it refractory, then add central venous catheters, correct the acidosis, and do further diagnostic tests. So for persistent vasoplagia, lower the MAP target, reduce sedation, consider midodrine. So once you're finding that the patient is having persistent shock, then or new shock, then look for undiagnosed infection, rule out other causes of shock, that is cardiogenic, hemorrhagic and obstructive, and also consider adrenal insufficiency. Regarding possibility of MAP underestimation by the peripheral artery line, better to put in a central artery line, that is in a femoral catheter. Regarding acidosis, correct the acid-base status by bicarb or CRRT. Regarding the other strategies, you can use methylene blue and inhibit the nitric oxide. So finally, summarizing, once the patient comes with shock, start with NORAD. If the dose is getting escalated, then add a second vasopressor, put a central venous catheter, central arterial catheter, add hydrocortisone and fludrocortisone, follow the diagnostic evaluation that was just given. If the patient is improving, then but there is a persistent low dose requirement, you can consider lowering your target, reducing sedation and midodrine to wean the patient off. If the patient is worsening, then you can escalate therapies like correcting acidosis, giving methylene blue, readdressing your diagnostic workup again, trying to find any other cause of shock, readdress the patient's goal in the light of worsening prognosis, whether we should continue the line of treatment or not. Thank you for your patience.